Strategy and Delivery Foundation, Ingress Health and Partners, mDoc, and of course, Institute for Healthcare Improvement, IHI. Next slide, please. We cannot appreciate our hub experts enough. Thank you so much for all your support over the years in, supporting teleeducation sessions from RICOM to Project Aisha and even Digital Moms Project. We appreciate your support, and we send you all the love and light. Next slide, please. It is important that we, acknowledge that we collect registration during the sessions, and these registrations will be used for reports and research purposes, right? Your private information is safe with us, just highlighting that. Next slide, please. Also, please note that this session will be recorded, and the recordings will be shared, after the session via email for participants who registered. Some housekeeping rules to guide us throughout the session. Please have your cameras on so that we can have a very engaging session and, look at the beautiful faces that we're going to be engaging with today. If you want to speak, if you want to ask a question, you can either use the chat box or use the raise hand button on the Zoom platform, and the host or facilitator will unmute you and have you speak. If you have any technical issues, you need any technical support, please just put that in the chat board or reach out to our technical team in the chat board. The person's number has been put in the chat. Josephine Obi's number has been put in the chat, so please reach out to her if you have any technical issues. Next slide, please. So just a quick snapshot of what our agenda for today is. We started off with welcome and introductions and guidelines. We're going to go through a quick snapshot of quality reviews, quality of care reviews from NaviHealth that are related to, labor and delivery. And of course, we'll get into, pre-quiz. Like we said, we take pre-quiz and post-quiz questions just to help us understand the knowledge gain from the session. So after the quality of care reviews, we'll get into the pre-quiz and of course the didactic session on guided labor series, best practices for optimal care. And then we have a lovely case presentation that we're going to, engage on and have a conversation around. Then we get into, questions and answers and, a robust discussion around the topic. And then we'll do the post-quiz and wrap the session up. Next slide, please. Before we get into this, in order for you to help us serve you better, we have put together a survey tool just to help understand the digital literacy of the healthcare workers that we work with and to understand their digital needs, right? So that survey we put in the chat. Please take 2 minutes of your time. The survey questions. Those survey questions are just going to be used to help us improve the services around capacity building, digital literacy, AI literacy that we're providing to you. So please, the survey questions, the survey link will be posted in the chat. Take 2 minutes to respond to it. Thank you. Right ahead. Using mDoc. mDoc is a digital health and enterprise that provides self-care support to people living with or at risk of chronic health needs. We do not replace facility-based care. We only complement the wonderful work that the facility is doing. And we do this through a high-tech, high-touch approach, a 4-pronged high-tech, high-touch approach using our products, CompleteHealth. So CompleteHealth is a coach-led, AI-enabled digital platform that provides self-care support, personalized healthcare plans and digital nudges for our members. This is a web-based as well as, app-based platform. We also have NaviHealth platform. This is a geo-coded digital directory for healthcare providers and facilities. Would usually call it the Google for Health. So if you are in Ikeja, for instance, to get ANC, you can go on NaviHealth and check for. If you are in Ikeja, for instance, and you're trying to get ANC, support, you can go on NaviHealth and search for ANC clinics and NaviHealth to take you right to that clinic. Patients are also able to leave quality of care reviews on NaviHealth. Just, a point of note for Project Aisha, we are utilizing NaviHealth to integrate the voices of women into the design and implementation of the project. We also have the mDoc Quality Network. This is our platform for capacity building, just like we're doing right now, building capacity of healthcare workers, as well as the members that we serve. And then finally, we have our in-person Nudge Hubs. This platform provides the opportunity for us to meet one-on-one with our members and provide that in-person support, guidance on digital and health literacy. Next slide, please. Next slide. If you're interested in signing up on CompleteHealth platform, the link is in the chat. If you're interested in signing up your facility or leaving a review on quality of care from NaviHealth, the link is also in the chat. Please feel free to click on it and leave, reviews on quality of care. Next slide. This is just a quick video on how to, register or sign up on NaviHealth, as well as leave a review on quality of care.
Hello, in this tutorial I'll walk you through the sign up process on NaviHealth. The first step is to enter navihealth.ai into your web browser. Next, click on the sign up button you can find below. Choose from one of the options to register either as a patient, facility or healthcare provider. Input your details. You can use a registered phone number or email address of choice, but please note that using a registered phone number is compulsory. Make sure to create a strong password. Once you have done that, click on the Finish button to be redirected to input a 6-digit verification code. Get this code sent to your email or your phone number and click to verify the button to complete the sign-up process to get started on NaviHealth. Once the sign-up process is complete, search for a healthcare service close to your location, and once the result pops up, you can search for a facility close to your location. Once you search for a facility, you can click to leave a review on that facility. Make sure your reviews are 100% authentic and original. Input a display name which is not your profile, and thank you for using NaviHealth.
Thank you so much for that video. So NaviHealth link is in the chat if you want to leave a review, or even look at reviews that have been left about your facilities. Please use that link, to get access to it. This is just a snapshot of what women have been saying concerning labor and delivery, right? There are some positive, there are also negatives, but that's why we're here. We're here to learn and, improve on, the quality of services that we provide to the patients. So around patient-centered care, they have been wonderful. We are told necessary and like what to eat and what to expect during labor. When I was rubbing my back, which is hospital. So you see that the little things count, and these women are taking note of it and writing about it. In terms of the negative reviews, they have the basic equipment required. I gave birth to my son here, but their customer service is a bit poor. So it's not enough to have all the equipment and have good facilities. You also have to have good patient services and patient-centered care. There's also one around, I did ANC of my first child here, but I didn't give birth here because the matron here then insulted me, right? So we're learning and we're growing and we're learning how to better serve our patients. Next slide, please. It's time for the pre-quiz. Like I said, no one is going to be judged individually for this quiz. It is a collective quiz that will be taken for us to understand the knowledge that was gained from this session. So please, please, please participate in both the pre-quiz and the post-quiz. It's going to be launching now. It's also important for me to mention that this session is being live streamed on YouTube. So if you're on YouTube participating on this session, this quiz will be shared to you through a Google survey, and it will be put in the chat. Please feel free to participate, on the quiz, both the pre and the post quiz session. The quiz is live right now. And it's going to be on for 5 minutes, and the time is counting now. So 5 minutes has started. I see that we started taking the quiz. Thank you so much for everyone that has started. If you're yet to start, it's 9 questions just around labor. no need to worry if you get it. You know, the session hasn't been done yet. There will be robust didactic session. And of course, the quiz will be launched again after the session. So please feel free to start it. I see, you know, some of the participants have already started taking the quiz. Thank you so much. I want to encourage everyone to please take the pre-quiz. It's been launched. If you have any issues, if you cannot see the quiz, please just put it in the chat and someone from the team will support you to have it launched on your screen. If you cannot see it, if you're having any difficulties, if you're having any challenges, someone from the team will support you to get it back on track. Can we have someone help Olumuyuwa in the chat as well as Ikechukwu access the quiz? We have 3 people on the chat that are having difficulties accessing the quiz. Can we help them? You can click on if you look at your Zoom, there are some tabs on the bottom. There's some tabs on the bottom. There's one that has more. If you click on more, you see poll quizzes. You can click on that and the quiz will be launched for you. And if you're still having difficulties, someone from the team will support you in the chat. Thank you. We're already 2.5 minutes in. We only have 2.5 more minutes left for the quiz. Please, we have a good number of people on the call. Can everyone please participate in the pre-quiz? Is there anyone that still can't see the quiz? Is there anyone that still can't see the quiz? Please indicate in the chat. We're 3 minutes in. We need more people. We need more participants taking the quiz. It's only 9 questions. Like I said, no one will be judged individually for their responses. It's a collective assessment of knowledge gained from the session. We need more people taking the quiz. We don't have a good number. Please, if you're on the call, please participate in the pre-quiz. It's launched. If you're having any difficulties, post in the chat and we'll help you. If you cannot see the quiz on your screen, click on the more icon at the bottom of your screen and you see poll quizzes there. Click on that and you should see the quiz questions. It's only 9 questions around labor and delivery. Can someone please provide support to Emmanuel? Let's keep the responses coming in. Let's keep the responses coming in. I think that going forward, we're going to start giving gifts to the first person that finishes their quiz. Would you like that?
I'm sure we will.
Let's keep the responses coming in. Let's keep them coming in. I'm going to give 1 extra minute. 1 extra minute for us to just wrap this up. We have a good number of people on the call. If you're just joining the call now, please participate in the pre-quiz. Like I said, it's just going to help us collectively understand the knowledge that was gained from this session. So please, it's up, it's 9 questions. I see people are responding. We have 1 more minute, less than 1 minute now to wrap this up. Thank you. Thank you so far for all your responses. Thank you. Let's keep it coming. Oh, thank you, Sekina. Thank you. Let's keep the responses coming in. We're wrapping up now, and in the next few seconds, let us keep the responses coming in. Let us keep the responses coming in. If you just joined the session, please, 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 it's only 9 questions. No one is going to be judged individually on this quiz question. It's a collective analysis of knowledge gained from this session. So yes, we're getting ready to shut the pre-quiz down. Getting ready to shut the pre-quiz down. If you haven't taken it, please wrap it up. Okay, so we're shutting the pre-quiz down now. If you haven't finished, wrap it up. You have 1 more second to wrap this up. Thank you so much for your responses so far. Thank you, everyone that has responded so far. We can go ahead and end the pre-quiz. Thank you so much for your responses. Can we also just repost for the participants that just joined now? Can we repost the survey, the digital literacy survey in the chat for the participants that just joined now? So like we said earlier, this survey is just to help us understand your digital literacy needs and help us fine-tune the services that we provide so that we can serve you better, right? So please take 1 minute or 2 minutes to fill out the digital survey questions that have been posted in the chat. Next slide, please. It's time. Drum rolls, please. We're welcoming our facilitator, our expert for today, Dr. Afalabi, a consultant obstetric gynecologist. He is an astute obstetrician and gynecologist specializing in maternal fetal medicine. He has clinical experience and the required skills to manage complex and high-risk pregnancies and births. He is a dedicated, goal-oriented team player with exceptional patience and determination in achieving set objectives and targets. He is a fellow of the West African College of Surgeons, the National Postgraduate Medical College of Nigeria, and the Department of Obstetrics and Gynecology. He currently has over 15 years of clinical experience. Wow. Including over 6 years of postgraduate training in obstetrics and gynecology. He holds a bachelor's in medicine and surgery from the College of Medicine, University of Lagos, Nigeria. He's currently a consultant in the Department of Obstetrics and Gynecology, Federal Teaching Hospital, Idu Ekiti, and a lecturer with Afe Babalola University, Ado Ekiti. He's happily married with children. Drum rolls, please, for our expert speaker, Dr. Afalabi, as he comes up to take the didactic session. If you don't clap, he won't come up. So please clap, put your claps in the chat as we welcome him. Thank you so much, Dr. Afalabi, for supporting on this session. Can we unmute Dr. Afalabi, please?
Yeah.
Thank you so much, sir.
Good afternoon, and thank you for the introductory aspect. I actually want to say a very big thanks to the organizers of this section, the Project Aisha and the mDoc. I want to also welcome all the participants from all over the country I want to thank you for your patience and for giving a time like this to join this series. Sorry, can they start sharing the slide? I'm not seeing the slide. I want to welcome you.
Thank you. Can you move to the
Yes.
next slide, please? Okay, yes, thank
All right, so the slide. So once again, you're welcome. The slide is not showing, please. All right, so this afternoon I will be, speaking on the management of labor, and it's something you are all familiar with. We all know that. The next slide.
Okay, apologies. It's probably a technical issue. The screen will be back up any second from now. Please just give us a few seconds to fix this.
Is it from my hand? Okay.
Yes, it's back up
Thank
now.
you so much. All right, thank you. Next slide. So we all know, so you can move to the next slide. Next slide. Yes, so we all know that Nigeria is one of the countries with the highest number of maternal mortality and also perinatal mortality. And 1/3 of the maternal deaths occur actually during the first half of pregnancy, during pregnancy, labor, and also during the period of puerperal, that's immediately after delivery. And most of these deaths, especially in low-resource countries like Nigeria, are largely preventable, and due to if there are timely intervention and there's an effective, way of managing labor and its complication. So it has been estimated that about 1 in 22 pregnant patients, pregnant women, are actually at risk of dying during pregnancy, labor, and as well as during the postpartum period. So our aim is to actually reduce this maternal mortality as well as morbidity by offering a woman in labor or pregnant patient in labor a positive experience by allowing a woman to have a healthy fetus with utmost satisfaction. Next slide. So you all know that labor is a clinical diagnosis. You don't need a test to make the diagnosis. And that is the reason why you need to know how to make the diagnosis of labor to differentiate it from the Braxton Hicks contraction. And it's defined as an onset of irregular, painful uterine contraction, resulting in progressive cervical dilatation and effacement, ultimately culminating in the delivery of the fetus and the other product of conception, that's the placenta. So we all need to know how to make the diagnosis, because without diagnosis, there's nothing we are managing. So diagnosis first, by recognizing the definition, the parameters to actually check, and then subsequently the management. Next slide. So for ease of classification, the labor has been categorized or classified into 4 stages, 3 main stages: stage 1, stage 2, stage 3, and the new one, or the newest one, is stage 4, which is actually the part of a postpartum period. Move to the next slide. So the stage 1, we all know that stage 1 begins with a regular uterine contraction and ends with complete cervical dilatation at 10 centimeters. It is divided into 2 parts, the latent phase and the active phase. Previously, we defined latent phase as from the beginning of or the onset of labor up to the 3 or 4 centimeters cervical dilatation. But recently, it has been reviewed, and the new cutoff point for latent phase now is 0 to 5, meaning that the active phase is starting from 5 or 6 centimeters up to the point of 10 centimeters. So active phase is actually the part of rapid cervical dilatation and descent of the fetal presenting part. I will talk more about the latent phase and active phase when I get to the whole partograph. Can move to the next slide. Thank you. So second stage is from the onset or from the end of this full cervical dilatation up to the time that the baby is delivered. That means from the end of first stage up to the point that the baby is delivered is actually the second stage, and I'm sure we are all familiar with it. The only thing that has changed over the past few years is the duration of the second stage of labor in both nulliparous and in multiparous women. Previously, we all know that once labor exceeds 2 hours, the second stage of labor exceeds 2 hours in nulliparous, it is considered as a prolonged one. And when it exceeds 1 hour in multiparous, it's also considered to be prolonged. But the new thing now, or the new thing now, is that labor can actually, in the multiparous women can actually, last second stage can last up to 2 hours. While in nulliparous, it can actually be up to 3 hours. So 2 and 3 hours are the new cutoff point for nulliparous and multiparous, for multiparous and nulliparous women. Stage 3. Next slide. So stage 3 essentially is the period of delivery of placenta, meaning that from the end of delivery of the fetus to the end of the delivery of the placenta usually lasts about 10 minutes. And there's an arbitrary cutoff point of 30 minutes to say that the third stage of labor is actually prolonged. But it's not in all cases, because if the third stage of labor is exceed 30 minutes, provided that the patient is not bleeding, there's no cause for alarm. You can wait and watch and see the outcome of the third stage. So not in all cases that once it has exceeded the 30 minutes period, you take the patient to the theater or for manual removal. The next slide. So that is briefly the concept of first stage, second stage, and third stage. The first stage is basically the postpartum period. That means the period after delivery of the placenta up to 1 to 2 hours after the delivery. And that is what we call a golden hour, because that's the time that the unrecognized postpartum hemorrhage can actually occur for everybody is actually with the baby or the mother is lying somewhere. That's the first, and it's a new concept. It's a fourth stage of labor. So understanding this concept of stages of labor will now lead us to the management of labor with respect to the stages. Next slide. So what do we do generally? The management of labor entails taking adequate history when the patient comes to the hospital. We want to review the record of the woman. We want to see whether the patient falls into what we call high risk or low risk. Low risk is those ones without risk that can affect the outcome of the pregnancy. And the high risk are those ones with medical problems or the things that can actually impact or reduce the chances of successful vaginal delivery. So thereafter, so part of the history to want to know whether the woman has ruptured membrane, the fetal, the perception of fetal kick, vaginal bleeding, and all those things that can actually signal, what they call it now, they can signal that the patient is actually qualified to be called high risk. After history is examination, you want to examine the fetus, both mother and the baby. You want to examine the baby, the mother, you take the vital sign. You want to also know the life of the patient or the baby, the presenting part. Then you also want to know the fetal heart rate, which is very, very important. So after all this, you'll be able to make your assessment whether the patient is truly in labor. And if the patient is truly in labor, is it latent phase? Is it active phase? Is it second stage? And thereafter, you can decide to admit. Let me add at this point that before now, because of the concept of 0 to 3 or 4 cm for latent phase, usually when a woman is in first central dilatation above, we normally admit the patient in labor ward. But the current thing now is that if a woman is up to 5 centimeter, like up to 5 centimeter dilatation, it should still remain on the ward. But from 5 centimeter and above, so less than 5 centimeter, admit the patient on the general ward. And for 5 centimeter and above, that is when you can refer or you can transfer the patient to labor ward. So after the history and examination, the next is investigation. You want to take the PCV, the serologist training, and every other investigation that may be necessary for the particular patient. The next slide. All right, so this is just the diagram showing how you make your the examination of the fetus. You want to know the lie, what occupies the lower part, and to know whether it is cephalic or breech. Next slide. So generally, what we do in management of labor is not different from what we have been doing. Just for little additions now in the concept of the new management of labor. What you do is general care. You do general care like for every other patient. The only difference in the general care now is that the issue of having to shape the pubic hair of the patient is no more accepted, and the concept of enema before the second stage is also not recommended any further. This second aspect is the most important part, the psychological support I could see from the earlier slide that was projected, people were complaining about the attitude of matron, the reason why they are not planning to take their delivery in one particular hospital. And this under this, and this is why WHO is advocating for supportive care in labor. And supportive care starts from where you are giving the psychological support, because that will also prepare the patient for the active stage and the second stage of labor. Is to make the patient relax, and that is why we are advocating for patient-centered labor care as a patient-oriented labor care. So apart from psychological care, you still do your labor monitoring and progress, fetal well-being. Then you also prepare for eventual delivery of patients by setting up the instruments you are going to use, and also prepare the labor room for delivery. Next slide. So what has changed? We all know that from the history, when we want to manage labor, we all use partograph. Partograph has always been the instrument, and we know that this partograph has also helped to reduce the incidence of obstructed labor, prolonged labor, and maternal morbidity mortality. From the history, from the works of Friedman to the work of Philpott down to WHO partograph. Initially, WHO partograph was designed in such a way that it contains the active phase and the active phase and the latent phase of first stage of labor. And the way it was designed, it was actually meant for mainly first stage of labor, not for second stage of labor. And when they realized that there's actually no particular time to say this is the onset of a latent phase of labor, or a specific duration of latent phase of labor, it was removed. And we were left with modified WHO partograph, which is what we use, and that in most centers, they still use to date. And this modified WHO partograph is the one that contains the active phase, the alert line and the action line. And this action line and alert line was based on the principle that the expectation of cervical dilatation in labor should be at least 1 centimeter per hour. And also, there are some other things that were actually not included in the WHO partograph. And some of the scholars have actually criticized this decision because they believe that there's no linearity. It's not always linear that a woman will have 1 centimeter cervical dilatation in labor. Some can actually start very slowly and they end up with the labor becoming very faster towards the end of delivery. So that's why the concept of changing the latent phase from 3 to 4 centimeter now to 5 centimeter, because they believe that the maximum cervical dilatation starts around 5 cm to around 5 to 6 cm. So that is why we are advocating for individualized patient care with the use of the labor work care guide. And after this WHO partograph, what was invented is also a simplified one, which is the color-coded partograph that are mainly made for the use of the midwives. But the recent thing now, based on the complex of patients, the review of the action and alert line, is the next slide, is the next generation partograph, the one we call labor work care guide. And this labor work care guide is not so different from the old partograph. The only thing that there are some other aspects that has been included. Some of the things that we think is more or less like formatting has been included in this labor work care. And why the changes? But they believe that there's an increase in over-medicalization of childbirth. Following the alert line and action line, they realize that sometimes, when the healthcare worker is using the partograph mainly to monitor the patient, sometimes it leads to early intervention, which can actually increase the cesarean section rate. And that's one of the reasons why they're looking at it that a woman should be allowed, to have her own birth and to follow our own pattern of cervical dilatation and delivery pattern. Next slide. So now let's also look at the labor work care guide and the old partograph. What are the differences in the two? Like I said earlier, that the labor work care guide was actually an extract from the old partograph, or just a modification of old partograph. The both of them still have the biodata part. That's the first part, that's the section of the labor work care guide, which is equivalent to the biodata component of partograph. It's essentially the same thing. The only addition with the labor work care guide is the the aspect of risk factor. The risk factor has been included so that when you see the graph at a glance, you can know whether this is high risk or low risk. And when it comes to the supportive care, there was no supportive care in the old partograph, no supportive care, which has been included. And you can see from the old slide where people were complaining, and the aspect where patients complain more is this aspect of supportive care. When we talk about companionship, and they have a companion in labor, the aspect of pain relief or pain management, and the issue of fluid in labor, as well as mobility. These are the supportive care. And we believe that this supportive care is actually central to the concept of positive pregnancy and labor experience. However, the care of the baby is essentially the same thing, care of the baby of fetal condition. The only addition here now is in the old partograph, there is no caput. There's no space for caput monitoring. Meanwhile, in the new one, the caput has been included, and there's also, because we all know that caput are molding the indicators or the signs and symptoms or signs of poor progress in labor, obstructed labor, or cephalopelvic disproportion. So apart from the caput that was included, then the monitoring of fetal heart rate has also changed. On the old partograph, the fetal heart rate used to be 120 beats per minute to 160 beats per minute. The recent one now is between 110 to 160 beats per minute. And how you monitor to has changed. When you want to listen to fetal heart rate, you can use intermittent auscultation with either with the PNAD or with the Doppler. But for a low-risk pregnancy or a patient with low-risk pregnancy, there is no need of continuous fetal electronic monitoring. That's the new concept now. Then how you monitor to, you want to monitor fetal heart rate, you start at the time of contraction or in the middle of contraction, and you listen towards the end of the contraction. You listen about 30 seconds after the cessation of the contraction. And the reason is because you want to know whether there's what we call deceleration. Ideally, there should be increase in fetal heart rate when there's contraction, or the fetal heart rate can remain normal. But when there's a contraction and there's a drop in the fetal heart rate, that is deceleration. And we have three types: late, variable, and early deceleration. So early deceleration is a variant of normal, especially when the fetal is being compressed, and the variable. But when there's a late deceleration, it's a problem for a patient in labor. The care of women essentially is the same. The only difference is now you have to put it in a numerical form. There's no point plotting of graph anymore, no plotting of graph or joining the line. You have to put it, if it's 150 if it is 96 beats per minute, you write it as the way it is. So the medication too is the same way. The labor progress is the only part that has also changed. Like I said earlier, the commencement of labor care guide is from 5 centimeters or 6 centimeters, no more 4 centimeters. And there's no alert line and there's no action line. And the duration of labor with the labor care guide now is about 12 hours, a range of 12 hours for a nulliparous and 10 hours for multiparous patient. Medication part is essentially the same. And okay, the new part is the shared decision making. And this part is also as essential as the supportive care, because this is the part you're supposed to explain to the patient all the findings and let the patient know your plan. And you carry the patient along in the language that is culturally acceptable, not like a matron insulting the patient because of asking for the stage of labor that the patient is currently experiencing. Then, just like the other, we also have postpartum period where you record all the events that has happened in labor. So essentially, the labor care guide and the old partograph, they are similar in some area, just for all the area that I've clarified. Can we move to the next slide? So how do you use it? The first thing to assess. You assess the fetal well-being, assess the woman. The next thing, after assessment, you are going to record it, and that is the way you're going to put it on the labor care guide. After recording, you want to compare with the threshold. There's a reference value to know whether it is normal or whether it is abnormal. And when it is abnormal, there's a column for that is defined as alert. It's just to tell you that either you need to intervene, or you call a senior colleague, or you refer a patient as this case may be. And after checking, you have to decide on what to do, and you record it accordingly. Let's go on. Next slide. So let's look at the each part of the labor work care guide. This is the part for identify information and labor characteristics. Like I said, you can see that this risk factor is like the new thing that was added. Every other thing is also the same, like old partograph. So this one will give you an idea of whether the pregnancy is high risk or low risk. I move to the next slide. All right, the supportive care. The aspect of supportive care, there are 4 different components. This was not part of the old partograph. So there are 4 components. That's the companionship. That's to allow the woman to have a companion in labor, whether the husband, the relative, or it could also be the healthcare worker. So on this column, you can see when there's a companion, you put yes. If there's no companion, you put no. And this is the thing you review every 1 hour and you record it. And this one will also, offer the patient the opportunity to be monitored closely. What about the pain relief? Yes, the pain relief can either be pharmacological one or non-pharmacological one. So you also need to offer a patient pain relief in labor. The pharmacological one will be petidine, morphine, but the choice of drug must be based on the experience of the health worker, because you have to consider the baby as well as the mother when you are deciding your drug. And the non-pharmacological one, you can use the breathing exercise, music, and every other one that falls under that category. Oral fluid is essential in labor to prevent dehydration, and a woman can be allowed to take liquid diet while in labor, especially at the first stage of labor. The posture, it is also established now that instead of restraining a patient to be on the bed, it can allow a woman to move around. Patient can walk, patient can kneel down, patient can squat, and mobility is what is being pushed for now, instead of restraining a woman to be in a supine position. So whenever you have any of the variable that falls on the alert, this is the alert zone. You can see it on this column. You cycle it. So anybody that is coming to check the chart, they can see it at a glance that there's an alert. Variable. So that, and once you have an alert variable, is for you to intervene and do something before the next review. The next slide. So what about the care of the baby? I said it earlier that the fetal rate, the way you monitor the fetal rate, this time around you have to record it, the numerical value. If you are getting 113 beats per minute, you put it that way. And the range is still 110 to 160 beats per minute. So when you check the fetal heart rate, you have to check it for a full 1 minute, not 15 seconds that you multiply by 4. You check for the whole 15 minutes. And if it is normal, you put if it is less than 10, you cycle it. Less than 110 rather, you cycle it so that anybody can see that it's on the alert column. Then I mentioned the variability the other time. Once you have early variability or early deceleration of variable deceleration, that is still part of normal. But when you have a late deceleration, it is adjusted to the abnormal, so you cycle it. The meconium and the meconium is still like the other one. Meconium is another blood stain. You still record it essentially like the old partograph. The other part that was actually added is the caput. Caput is the diffuse swelling on the fetal scalp. So it can be mild, moderate, and severe. The mild and moderate is adjusted to still be a variant of normal, but it just calls for more vigilance, especially when you are reviewing the patient. But when there's a caput of 3 pluses or model of 3 pluses, that should alert the caregiver, so to be able to call for the superior or to decide on whether to refer patient based on the protocol within the hospital setting. You can see this slide that there's a second stage. Sorry, next one. There's a second stage which we did not have in the old partograph. There's a second stage with the new partograph. So this is what I've explained earlier. So the next slide. For the care of the woman, essentially the same way. Again, you have to record it the way it should. 80 beats per minute, 120 beats per minute, you have to put it, and you monitor it anytime you want to monitor the pulse rate every 30 minutes. While the blood pressure, you do it every 4, just the way we used to do it with the old partograph. There's no difference in the way we monitor old partograph and the new partograph. So the next slide. So when it comes to the cervicogram aspect, which is the area that is dealing with the fetal, the descent, and also the dilatation, it's good for us to know how to actually examine a patient to know the station of presenting part, which will help us to know the level of descent. So the descent can actually be done either vaginally or abdominally. You can see it on the left side, it can be done abdominally using the rule of fifth. That's if it is 1/5 palpable, second to fifth palpable, and non-palpable. And the vaginal examinations based on the line at the ischial spine can be -1, -2. It is minus when it's above the plane of ischial spine, and it is plus when it is below the plane of ischial spine. Next slide. So aside the station of presenting part is to also monitor the dilatation and effacement. You can see this is when the os is still closed. You can see it's a phase, but just about 2 cm, and this is full cervical dilatation using the same rule that we use with our fingers and to measure. So once you understand the concept of monitoring a patient with the station and dilatation, then it will be easier for you to plot it on the labor work care guide. Next slide, please. Yes, so this aspect is the one that is really the main after the supportive care about the labor progress. What you want to know about the labor progress, you want to see whether the patient is having adequate contraction or not. And what we used to do before is to also plot, like you have a column, a box, where we used to shade the number of contraction, whether the contraction is less than 30 or 35, whether it's greater than 40. So, but in this one, it's already there. You have to enter it numerically too. If the contraction is less than 2, you cycle it. Less than 2 in 10 minutes, you cycle it. If it's greater than 5, you also have to cycle it. And the reason why a patient can have more than 5 contractions, especially when there's hyperstimulation. And this one can also lead to uterine rupture. So you have to cycle it. Then the duration of contraction is per second. So when it's less than 20, that's have to be alert. You have to decide whether you have to intervene, whether you want to augment or not. And when it's greater than 62, it will also mean that the patient is having hyperstimulation and you need to also intervene. So what you do mainly in labor work care guide is essentially the same with the old partograph. You have to plot, but the only thing that you're plotting, you're starting your plotting now from either 5 or 6 cm. You can start from 5 cm. And each of them have their duration. So if you are starting from 5 cm, it is expected that that labor should not exceed beyond 6 hours. If you are going to 7 cm, it's expected that it should not go beyond 3 hours. So wherever you are starting from, and it's expected to still follow the old pattern of cervical dilatation. So when you want to plot, you use X to plot. There's no difference from the old partograph. And for the area of descent is when the fetal head is coming down through the birth canal. So based on your findings from the either abdominal examination or vaginal examination, you have to plot your descent. You can see the way descent is coming when you get to station 0, maybe 2/5 palpable, and these are the things you put. So when it comes to management or monitoring, it's still the same way. Still use 4 hours in labor, except if it's otherwise stated or when the patient is having it all together. So there's no difference apart from the fact that there's no more alert line and there's no more action line. Can we move to the next slide? So what are the things that could cause abnormal progress in labor? We all know that if the labor is slow or it's not, there's no progress in labor, it could be due to 3 delays or 3 Ps. It could be as a result of the passenger, whether the baby is too big, like a patient with macrosomia, or there's anomaly like hydrocephalus, or maybe there's abdominal tumor. So it will also delay the progress in labor. It could also be related to power, whether the contraction effort is inadequate or the maternal effort is very poor, especially in the second stage of labor, where you may need to use assisted or operative vaginal delivery. It could also be as a result of passage, like contracted pelvis, or maybe due to soft tissue problem. Next slide. So aside this one, the area of medication is still part of the new labor work care guide. The oxytocin we normally give is still there. The only thing is that if you are not giving oxytocin, you can put the label as normal. If you are giving oxytocin, you have to put the international units per liter and also the top rate. It's not different from the old one. The only part is that you have to continue to the second stage of labor. And the other medication too, just like the other one too, you have to put the medication. If you are giving cefuroxime for a patient with prolonged PROM, you have to indicate. IV fluid is actually not routinely advocated in the new care of patients in labor. And the reason is that they believe that if a patient is taking is having oral intake regularly in labor, the risk of dehydration is less. And since they want to encourage the woman to move around the labor, to have mobility, if you are putting a patient online, it means you're also restricting the movement of that patient, which may actually prevent the positive pregnancy experience. So you do all this until the second stage of labor. All right, so assessments. After you have done all this, you have to put your assessments. If you think your assessment is CPD, you have to record it. If you think assessment is that this inadequate suicide contraction, it must be recorded. And thereafter, you have to put your plan. You put your plan on what you want to do, and you sign. At the level of second stage of labor, like I said earlier, that usually before, it used to be 1 hour for multiparous and 2 hours for multiparous. You can see this area now, you can see that it's 3 hours now. So the new one is 3 hours for nulliparous and at least 2 hours for multiparous women. And so when the woman gets to the point of second stage and it's about to push, you can denote that part with P to signify the onset of second stage of labor. So essentially, there's really no difference. Even when you use the whole partograph, you can see it incorporates these little findings or little things in labor work care guide for a woman to have a positive pregnancy experience. Can we move to the next slide? All right, so delivery of patients is still as the way we used to do it. There's no difference. Next slide, there's no difference. Move to the next slide. So what you want to do, once the head has crowned, you want to assess for episiotomy. Episiotomy is not routinely given. There must be an indication for episiotomy, especially when the perineum is threatening to tear. You want to give episiotomy. And they also want to guide the perineum to prevent laceration or to prevent perineal laceration or vaginal laceration. So once the head of the baby has been delivered, the first thing is to do is to clean the mouth, then check for the neck for any possible cord around the neck. And if it's something you can slip over the baby's head, you try to do it, but if you can't do it, double clamp and cut. And deliver the baby with gentle downward traction and gentle upward traction to deliver the posterior shoulder. And let me say at this point that the concept of fundal pressure to deliver the second stage of labor is actually not recommended. That the old CRED maneuver is no more in vogue. So what we do mainly is the normal management of second stage of labor. Can we move to the next slide? So after normal delivery, you hand over the patient to the neonatologist, and it's not also essential to when the patient is breathing spontaneously. There's no need for suctioning. There's no need. Once the patient is breathing spontaneously and the abdominal score is normal, then just hand over the baby, and you go ahead with other part of the labor. Yes, there's something I didn't mention under that part. The cord clamping, yes, it is now the new thing is late cord clamping. And late cord clamping, that means you shouldn't clamp the cord anything less than one minute. And this one helps to mix some blood to the baby and help with the iron storage for the baby. But in the case where you see a baby with obvious asphyxia, it is not the time to waste. It's not the time to waste time in transiting the giving the patient to the pediatrician for active resuscitation. So that's the end of second stage of labor. For the third stage of labor, there are two types of management. There's an expectant management where you don't use oxytocin, you allow the placenta to be delivered by gravity, maternal effort. But the problem with this is the risk of postpartum hemorrhage. But when it comes to the active management of labor, which is what is actually being advocated by WHO, you give oxytocin once the baby has been delivered, you give oxytocin either intravenously or through high M route. And you clamp the cord and you deliver the placenta by control contraction. But before you do the control contraction, you must be sure that the placenta has actually separated from the uterine wall. You can check the next slide. You can move to the next slide. You have to be sure that the placenta are separated from the uterus. So, and there are classical signs to know whether the placenta are separated. And the first is, you see, because of the reduction in the surface area of the placenta, that there will be the uterus will contract and rise, and there's a sudden gush of blood showing that it has truly separated, and there's a lengthening of the umbilical cord. So those are the signs one we see once the placenta are separated. And from there, you can, next slide, you can now apply what we call control contraction or Branzandrio. Next slide, Branzandrio maneuver. Next slide. So you can see this picture now. See, this is, no, the next slide, sorry. Yes, this one. You can see this slide, see the way to conduct the control contraction. It is called control contraction just to prevent the risk of uterine inversion. So the woman will hold with the dominant hand, maybe the right-handed person, you hold the cord and you put the counter-traction on the suprapubic region. Try to extend or to give a counter-traction to the uterus while you are dragging the placenta. This will prevent uterine inversion. So one of the management of third stage of labor is also to prevent postpartum hemorrhage, and that is the reason why we do what do you call it now, the active management of third stage of labor. In the absence of oxytocin, when you don't have oxytocin, you can also give ergometrine or you give misoprostol, either orally or per rectum. Next slide. So having done all this, you deliver the baby and you have completed the delivery of the placenta. It is time for documentation. You have to document all the findings. We have that one with the old partograph too. We have the finding, the delivery of the baby, and the time and the mode, whether it is SVD, and the exact time that the baby is actually delivered has to be documented. What about the state of the perineum? Is it intact? Do you give episiotomy? And laceration, if there's laceration, what degree? The use of anesthesia needs to be recorded. And how do you manage the third stage of labor, whether expectantly or through active management of third stage of labor? You also have to monitor the blood loss, whether it is less than 250, between 250 and 500, or greater than 500, that would qualify as postpartum hemorrhage. And what about the state of the baby, the presentation, the sex, weight, and the outcome that's based on APGAR, and also the maternal outcome. The maternal outcome, which the first stage of labor, is to actually check the woman after delivery, especially if within the first 1 hour or 1 to 2 hours after delivery. What you want to check, you see whether the uterus is contracting well, and check it every 15 minutes. But uterine massage is not allowed in the new labor care guide. It's not allowed. You check the vital sign. I want to also check the perineal part to see whether the patient is actually bleeding. Thereafter, within the next 24 hours, you can monitor the patient routinely on the ward. So that is, next slide, that is the concept of the new labor care guide. There's actually no difference between the old partograph and the new labor care guide, apart from the concept of the supportive care, which I think is what the patients are actually craving for. And you can see the feedback from patients, you know that aspect is very, very important. And those are the things that will help our patient to have a positive pregnancy experience. And when they have the positive pregnancy experience, I can assure you that we're on a path to reduce the maternal mortality and perinatal morbidity in our country. I want to sincerely appreciate you for your time in listening to this section. Thank you so much.
Thank you very much, Dr. Afolabi, for this very beautiful session. Please, I want to confirm if I'm audible before I continue speaking. Thank you. Am I audible, please?
Yes, you are. Yes.
Okay. Thank you very much thank you for this enlightening session. I, for one, I can say that I have updated my iOS, when it comes to the management of labor. It felt like I was in medical school again. Thank you so much for this presentation. At least for me, the key takeaway for me on the presentation will be, the inclusion of the supportive care in the WHO care guide. Before, people do not really care about, the emotional aspects, but now it's very important that it's not clear that it's very important for us to, have this holistic care for women, so that, and they also know that the quality of care a woman gets during labor is very pivotal, crucial to reducing maternal mortality and child health. Thank you once again for this presentation. I'm sure some of us have questions for Dr. Folabi, but please just kindly bear with us. Please put your questions in the chat box, which will be attended to after the case presentation. And just before we go to the case presentation, I would like to recognize Dr. Kenja Njoku from IHI. So just for those of us that are not clear, IHI is one of our partners, implementing partners on Project Aisha. They carry out the quality improvement part. I don't know if Dr. Kenja has anything to say to us. Dr. Kenja, please, you have the floor if you have anything to say to us this afternoon. Okay. Well, I'm not sure. Maybe she has issues with her network, but okay. So the next, please, next slide. So we're carrying out a case presentation just to give us like a practical experience of what we have learned. So that is one thing to talk about the theory. We also want us to discuss a practical aspect. So we are sure that to just emphasize what we have learned, and so ensure that whatever we are learning is speaking to everyone. Thank you very much. I would like to call on Dr. Nguti to take case presentation. So if you speak to Dr. Nguti co-host so that she can speak.
Okay, thank you very much, Dr. Marvelous. So we're going to be having a case presentation about the management of labor. It's a case that happened at Ekiti State University Teaching Hospital. So next slide. So we're presenting Mrs. AA. She's a 28 years old Gravida 2 para 1. This is her second pregnancy. She had one previous delivery. She presented at 39 weeks, 2 days, and she presented to the labor and delivery unit with regular painful contractions every 5 minutes over a 3-hour period. Each contraction was lasting approximately 45 seconds. She reported a blood-tinged mucus discharge, which is a show, but no rupture of membrane. Next slide. The patient's previous obstetric and medical history: she had a previous full-term delivery through a spontaneous vaginal birth without any complications. She attended regular antenatal visits at her local primary health care center in Ekiti and 2 follow-up appointments at Ekiti State University Teaching Hospital. Her antenatal checks, including blood pressure, glucose, and hemoglobin, were within the normal limits throughout the pregnancy. Next slide. So she presented her vital signs were stable. Her blood pressure was 118 on 75 millimeters of mercury, with a pulse of 80 beats per minute, a respiratory rate of 18 breaths per minute, and temperature of 37 degrees Celsius. The fetal heart rate at presentation was at 145 beats per minute, which is normal. Obstetric examination revealed a fundal height of 38 centimeters, consistent with the gestational age, and a vertex presentation. The fetal head was engaged, and cervical examination showed that she was dilated at 5 centimeters, 70% effaced, and a station of -1. So here was the management plan and the implementation after this assessment. So how the labor was monitored as follows. Mrs. A's vital signs were checked regularly with blood pressure, pulse, and respiratory rate monitored every 30 minutes, and the temperature recorded every 4 hours. Labor contractions were monitored for frequency, duration, and intensity. Fetal monitoring, she was monitored using the continuous electronic fetal heart rate monitoring, which ensured that there was fetal well-being with regular documentation every 30 minutes during the active phase. The level progression was documented also. They documented the cervical dilatation, effacement, and fetal descent, which was assessed and documented on the partograph every 2 to 4 hours. For pain management, she received both pharmacological and non-pharmacological support. For the non-pharmacological support, she received supportive care, including position changes, breathing exercises, and encouragement from the birth companion that was provided to manage her pain. For pharmacological options, they had intravenous paracetamol that was administered as needed with epidural anesthesia available if needed. And epidural anesthesia was also available if the labor became prolonged. Sorry, I just lost. Okay. If the labor became prolonged, or if she had desire for the epidural anesthesia. Next slide, please. So for her monitoring, there was also the consideration of her hydration and nutrition. She was provided oral fluids to ensure hydration with Ringer's lactate as an option if intravenous hydration became necessary. And she was also encouraged to have light snacks if desired, while solid foods were avoided to minimize aspiration risk should there be a need for an emergency cesarean section. In terms of the preparation for labor, the delivery room was prepared with necessary equipment, suction, oxygen, sterile delivery kits were checked and ready. The obstetrician, the anesthesiologist, and the pediatrician were all notified of her level, and the progression also was communicated. Mrs. A was also coached on bearing down and relaxation techniques. Next slide. And the management plan still involved the anticipation of potential complications. The staff were prepared to handle possible complications such as shoulder dystocia and postpartum hemorrhage. And they had uterotonic drugs like oxytocin and misoprostol who were prepped for administration if needed. And the pediatric team was also on standby in case the child needed neonatal resuscitation. For the delivery process, once the dilatation was full, was at 10 centimeters and station was at close to, Mrs. A was encouraged to push with contractions. Episiotomy was considered but not performed as per her delivery progress. The baby's head, shoulders, and body were delivered without complications. Next slide. And post-delivery, there was maternal postpartum care. Oxytocin was served immediately after delivery to prevent postpartum hemorrhage, and the placenta was delivered intact and was carefully inspected for completeness. Mrs. A's vitals were also monitored every 15 minutes, that's post-delivery. for the first hour postpartum, and no signs of bleeding or other complications were observed. For the care of the baby's ABGAS scores were recorded at 1 and 5 minutes, and they were all normal, or 10 on 10. The baby was cleaned, dried, and placed skin to skin on Mrs. A, encouraging bonding and promoting uterine contraction, and breastfeeding was initiated within the first hour. For her discharge and follow-up plan, she received postpartum counseling for family planning and nutrition. Mrs. A was scheduled for follow-up visits at her local primary health care center within 1 week. She was advised to seek immediate care if she experienced unusual symptoms such as expressive bleeding, fever, or pain. So in summary, next slide. In summary, we have just presented Mrs. A's level that was managed effectively with continuous monitoring, proactive pain management, and thorough preparation to delivery. She delivered a healthy baby without complications, and postpartum care was provided to ensure her and her newborn's health, and the structured approach ensured safety and comfort to Mrs. A throughout labor and delivery. Next slide. Thank you. So do we have any questions based on this case presentation?
Thank you very much, Dr. Nguzi, for taking your time to take us through this case presentation. Please, if you have any questions, feel free to drop them in the chat box, both for Dr. Nguzi and for our speaker. So far, I've not seen any question for Dr. Afolabi, so I take it that we all understood everything he has said, or we do not understand at all. Anyways, we'll determine in our post-survey question. In the absence of no question, please, we would like to proceed to the post-quiz. Josephine, please, you can launch the post-quiz. Are you there? Sorry, just before we start, Josephine, please, you can hold up back on the survey, please. We want our speaker to give his feedback on our case presentation. Dr. Afolabi, are you there? I don't know if I had some notes of you. Okay. Dr. Afolabi, you're unmuted now.
Yes, thank you so much, Dr. Anita, for the presentation. I actually want to commend the management team or the managing team for the way that the patient was actually managed. But there are a few questions I need to, ask. One is that this appears to be a low-risk pregnancy. Why the referral from a maternity estate or something to a teaching hospital, provided that it's, for the fact that it's a low risk? And secondly, the way the management looks, it looks as if she was actually managed like high risk. I know that because of the the limited personnel in the country now, I don't know whether we have all the personnel to actually put up all those things that you have mentioned to manage a one low risk pregnancy. Then the third one, the blood pressure was monitored every 30 minutes. I don't know how feasible. I don't know whether you used the old partograph or was just a common or maybe the general way of managing patients' blood pressure in labor. Then the use of CTG, and I think I mentioned it in my slide too, that for a low-risk pregnancy, there's actually no need for the use of CTG. Which other one? Yes, shared decision making. I didn't hear any parts where the patient was actually carry along rather, about the plan at each stage, whether he was explained to, this is what you are going to do, or something. Those are my questions. Thank you.
Thank you, Dr. Afolabi, for your, how would I say, your astute observations and questions. I think Dr. Ngiti is having network issues, so she might not be able to answer the questions. But you can provide your expert insights or maybe what you could have done better just as a learning session for every one of us on the call. Dr. Afolabi, can you hear me?
Okay, yes, I feel strongly that the patient who has actually booked and had the ANC, or let's say antenatal care at the either basic health center, where they have competent midwives, she should have delivered over there. And secondly, the pattern of monitoring of blood pressure in labor. If you are going to be monitoring blood pressure every 30 minutes, that means you also not put the woman, you not allow the woman to be comfortable with your monitoring. The woman that wants to move around, I want to allow to move around. But I think we should still stick with the 4-hourly monitoring. But if there's a patient with, pregnancy, hypertension, or preeclampsia, then we can do it regularly. Then I think I mentioned the use of CTG. There's no need for CTG in low risk. The use of epidural and analgesia to prevent prolonged labor is actually not given to prevent prolonged labor. And also, yes, some of the things are actually not measured, the weight of the baby, she also said something that skin-to-skin contact or skin-to-skin is to encourage uterine contraction. It's actually to reduce hypothermia, not to improve contraction. Thank you.
Thank you very much for your insights once again, Dr. Afolabi. Your feedback is well noted, and the next facilitator presents their management in the next presentation will ensure that all of this is incorporated. Then, okay, there's a question for you in the chat box, sir. How can we manage complications such as postpartum hemorrhage consistently in low resource settings?
Thank you for the questions. One of the ways to prevent postpartum hemorrhage is the active management of third stage of labor. And that's the active management of third stage of labor with the use of oxytocin to reduce the postpartum hemorrhage. And also for the low resource setting, the first thing to do is actually to identify the patient you are dealing with, whether it's a low risk or high risk. We have some patients that have the risk factor for PPH or postpartum hemorrhage based on the previous delivery, and those are not the candidates that should be monitored or should be managed at the low resource setting. But should you have a case of a patient with postpartum hemorrhage, you can still use your oxytocin. You can make use of the misoprostol. You can also still use the uterine massage when there's PPH, not when there's no PPH. Ergometry can also be used, but you have to be wary of the complication or contraindication to the use of ergometry, especially the patient with elevated blood pressure, that's PIH and pre-eclampsia.
Okay. Thank you very much once again for your questions. Okay. So someone is another question. I want to know, thank you, Dr. Afolabi, for your well-delivered presentation. I want to know, sir, why intrauterine massage is now not allowed in the immediate post-parturition period to ensure adequate contraction. Thank you. I'm sure I understand the phrasing of this question. Okay, I think the person is trying to ask, why is uterine massage not allowed in the immediate postpartum period to ensure adequate contraction? You know, after a woman has given birth, some people do uterine massage is used to, to encourage contraction, to ensure adequate contraction. So the person is asking why is no longer allowed.
Thank you once again. The concept of uterine massage is not actually allowed for prophylactic against BPH, because once the patient is not having postpartum hemorrhage, if you are giving your oxytocin, it is not advisable that you do uterine massage. Doing uterine massage can actually predispose the woman to having uterine inversion. But when there's obvious postpartum hemorrhage, you can do your massage. You can give oxytocin catheter. You can also put Foley's catheter, that's a intrauterine Foley's catheter, and also do other measures, especially when it is due to atoning. So it is because they have looked at it at the weight, and they have checked the. Oh, sorry, someone said you cannot hear. Can you hear me now?
Yeah, audible, maybe network.
Yeah. So that's the reason. But if there's PPH, you can do uterine massage. But for prophylactic against postpartum hemorrhage, it's actually not encouraged. It has been found out that it's actually not doing anything. That main thing for the third stage of labor is active management of labor to reduce the PPH.
Okay, thank you once again. So there's another question. I think this question came in the middle of your presentation when you were talking about the labor ward care guide. So the person is asking, is there room to write the specific pain relief administered?
You get the question?
Okay.
Is there what?
Is there room to administer to write the specific pain relief administered on the new labor ward care guide?
Yes, there's a role, and I mentioned it that there are two mode of what they call it, the pain relief. You can use the non-pharmacological means and pharmacological means. And when you're going to use the pharmacological means, the caregiver will need to understand the properties of the drugs you want to give based on the action, the time of action, and the duration of action, as well as the effect on the baby, as well as the effect on the labor or mother.
Okay.
So it's one of the component of the supportive care with respect to management of labor.
Okay. Justice Ebule is asking, thank you, Dr. Afolabi, for your presentation. How do we encourage the importance of shared decision making among healthcare providers, considering it is a new approach?
Yes, it's actually not a new approach. It's just because we have actually not been doing it. Because I know some people are actually doing it. It's just about explaining to patients, like, want to do something, you want to take consent, you want to explain to patient what you want to do, and you want to carry the companion along, and this is what you want to do, this is your plan, this is your decision. It's not until when you're about to move the patient to the theater, you now start telling the patient that you want to do some cesarean section. They'll start looking at you, and you're not carrying them along. So the shared decision is actually to start at the beginning of labor. And they even trust you more. By the time you're carrying them along and you're telling them at each stage of labor what they are experiencing, what you want to do, it makes your work easier. And they won't see you as a bad matron or one bad nurse like that. So you have to carry them along from the onset. At each stage, whatever you're going to do, if you want to drain the bladder, you have to let them know, take consent, this is what you want to do. So it's a way of actually, giving the patient a kind of respect and telling them everything that you are doing in labor. So that's the concept of shared decision making in labor.
Okay, thank you very much for highlighting the importance of, carrying the patient along in management because it's very important for best outcomes. There's one more question for you. What are the most practical and affordable interventions for monitoring fetal well-being during labor in resource-limited settings? Like, take for example, now this patient came from Ekiti State. So, and that's the case, not everywhere is Lagos. So we know that's the case in like a lot of places. So what are the interventions that are being used?
I didn't get that. Intervention for
For monitoring fetal well-being during labor in resource-limited environments.
yes, the labor work care guide is actually meant for patients or the healthcare worker in low resource setting, and that's why we know because it is not all health center will have a CTG, so that's why the use of peanut or the Doppler is one of the things we can use. It's just about the technique of how you monitor that really matters, and to know the range of the heart rate and the timing of deceleration to actually put it as whether you need an intervention or not. So in low resource settings, it's still the same way of using the peanut stethoscope or the Doppler to monitor the fetal heart rate. What is important is your frequency of monitoring and the technique of monitoring.
All right. Thank you so much. I mean, this session has been very, very, I know, interactive. It has been very enlightening. I've learned a lot. I'm sure all of us here have learned. Just before we go to the post quiz, I would like to recognize Dr. Lasumbo Makinde. She's the project manager for the project for HSDF, the prime project for Project Aisha. Please, if you are here, please recognize her in the chat section by giving her a round of applause for, thank you for your support, for joining us. Thank you for, your constant collaboration. Thank you so much. I don't know if she wants to say anything to us before we proceed. And if there are questions from YouTube, please let me know so that we can quickly ask before we go to the next session. All right, all right, all right. I guess we can proceed to the next section. Just simply kind help launch the post quiz, just to help us gauge the effectiveness of what we are doing. We want to be sure that people are listening, they've learned a lot. So we want to gain, the for those that joined later, before we started, we took a pre-quiz to gauge the average knowledge of the people that were joining the session. So we have to monitor the level of knowledge gained. Please take questions. This is very important that you answer the questions to help us understand. It's just a way of providing feedback to the organizers of this session to know, okay, are we effective? Are our members learning? So we can see if we need to improve, what we need to improve on. So please, I know it's a lot, but please just kindly bear with us and take the questions. Thank you. Please, if you have any issues with the questions, please put in the chat box. Somebody will assist you and put you through on how you can get the questions. Please use your chat box. If you're having issues, maybe technical glitches, you're not able to access questions, please put it in the chat box so that someone can assist you. Can you please assist Doris? She said she answered one question and it just disappeared. Thank you. I can see some of us already answering. Please let's keep it coming. Let us keep it coming. Thank you so much. Thank you. Really appreciate. Oh, sorry to hear that, Josephine. And Kenny, please, can you assist her if there's anything that can be done? Thank you once again. I see keep the questions, the answers coming in. Thank you. Thank you, Akiyemi, Grace. Thank you so much for taking the questions. Please, let's keep them coming. Let's keep them coming. So that we can quickly wrap up the question. Wrap up the session up, I mean. Thank you, Tolulope Benro. Thank you so much. Thank you for submitting your answers. Thank you. I think I'm with Chiagozie on this, so we need to start giving prize for first to finish. Thank you. Let's keep the answers coming. Yes, so seconded. I agree. We need to start. This is why this is important, so that we can know what to improve on. That's one aspect to improve on. You see the importance of collecting data. Please, we need more people to respond. Please keep answers coming. Keep the answers coming. Please kindly assist Osage. Please, this person cannot access the post test. Please, let's assist. Please, kindly, please. Thank you, Sakina. Thank you so much. Thank you, Bolaji. Thank you. Really appreciate you. Thank you for let's keep the answers coming. I want to encourage everybody to submit. Thank you, Bukola. Thank you for submitting. Thank you, Luatoyin. Thank you so much. Please, if you have not taken the quiz, please, I want to encourage you to take it. There's no judgment here. This is a safe space. Nobody is judging you. We just want to access the level of knowledge gained. So I'm going to give 1 more minute so that we can move on to the next part of this. 1 more minute for us to fill the post session survey. Thank you, Kristen. Thank you, Minat, for submitting. Thank you. We appreciate you. Please let's keep them coming. Thank you so much. Let's keep the answers coming. Again, this is a safe space. You're anonymous. We're not scoring you. There's no pass or fail. You just want to gauge the level of knowledge gained and the effectiveness of our sessions. Thank you. Let's keep them coming. Okay, so we'll be wrapping up this session in 20 seconds. Just before we leave, because I know some of us will want to leave now, I just need to let you guys know, as you know, you will know by now that we like data in mDoc. So we want you to just if you want to put a survey in the link, we're conducting a survey to just gauge your digital literacy levels. We want to assess your level of how you're able to use technology and AI. So please just take out time to fill the survey. It's not going to take long. Just in case you can end, let me just end it. I'll be ending the poll now. Thank you everyone for. The survey is the chat box. Please, before you leave, please just kindly take the survey. If you need any help, please let us know. Okay. All right. So while we are waiting for people to fill the survey, Dr. Afolabi, okay. Dr. Afolabi, are you still here with us? Dr. Afolabi?
Yes, hello, I'm with you.
Okay, so just before we wrap up this session, we just want, if you can, just want you to, answer the questions that, just to give people, just as correction for those that got it wrong, so they can know where they went wrong, and just for 5 minutes.
All right, so you can post it.
Just please launch the questions again so our speaker can. Okay, I'll be reading it. Which of the following best defines the onset of labor? Regular painless uterine contractions without cervical changes, regular painful uterine contractions resulting in cervical effacement and dilatation, irregular uterine contractions that soft to the cervix, painful uterine contractions lasting longer than 30 minutes, sudden rupture of membranes.
That's regular painful contraction.
Resulting in cervical effacement and dilatation.
Yeah.
Okay. At what point is the second stage of labor considered prolonged in a nulliparous woman? The 1 hour, 2 hours, 3 hours, 4 hours, 5 hours?
Answer is C, 3 hours.
Okay, thank you. Which of the following is the most critical step in managing labor to prevent adverse maternal and neonatal outcomes? Administering oxytocin drugs immediately upon admission, monitoring labor progress and identifying complications early, routine use of controlled contraction, ensuring the patient delivers within 12 hours, prescribing antibiotics to prevent infections.
Monitoring labor progress, find complications early.
Right, thank you. So you people should be taking note though. Which of the following is not one of the 3 P's that can cause abnormal progress in labor? Passenger, power, passage, partograph, all of the above are correct.
Partograph is not part of it.
All right. Which of the following is a feature of active management of the 3rd stage of labor? Delivery by placenta by gravity and maternal efforts, immediate clamping of the cord before placental delivery, routine use of oxytocin and controlled contraction, delay intervention for 60 minutes post-delivery of the fetus, using only manual removal of the placenta.
That's the correct answer. Is C. Use of oxytocin can control cord traction, otherwise known as Andrew maneuver.
Yes.
That's option C.
Okay, thank you. What is the expected range for a normal fetal heart rate during labor? Less than 90 beats per minute, 90 to 110 beats per minute, 110 to 160 beats per minute, 160 to 180 beats per minute, greater than 180 beats per minute.
Answer is C. 110 to 160 beats per minute.
Okay. Which of the following is a classic sign of placental separation during the 3rd stage of labor? Sudden rupture of membranes, contraction and rise of the uterus, decrease in the length of the umbilical cord, absence of vaginal bleeding, gradual softening of the uterus.
That's option B. Contraction and rise of the uterus.
Right. During the 1st stage of labor, what characterizes the transition from the latent phase to the active phase? Contractions become irregular and weaker. Cervical dilatation progresses rapidly, starting from 6 cm. The cervix dilates from 1 to 3 cm. Descent of the presenting fetal parts is completed. Amniotic fluid is released spontaneously.
The answer is B. Cervical dilatation progresses rapidly, starting from 5 to 6 years.
All right. So for the last question, which of the following best describes the WHO Labor Ward Care Guide's goal? To prioritize oxygen use in all deliveries, to monitor labor using predefined time limits for all women, to enhance individualized care and shared decision-making, to minimize maternal effort during the 2nd stage of labor, to eliminate the need for traditional parthographs.
The option C is the answer. To enhance patient-centered care and share decision making.
Thank you very much once again, Dr. Folabi. We have come to the end of this session. Just before you go, if you've not filled the survey, please fill the survey. Dr. Thank you so much, so very much for taking out time, for supporting us, taking time from your busy schedule to come and teach and lecture us on updating what we know about management of labor. Really appreciate you, and then we do hope that everyone here has learned 1 or 2 things from this place. Really appreciate you once again. Thank you so much.
It's my pleasure. Thank you so much. Thank you, everyone. Thank you to the organizers as well.
All right. Thank you. Please feel free to drop off. Sorry. Thank you everyone for joining this session. Really appreciate you. Thank you for supporting us. Thank you so much for taking our time to be a part of the session. Thank you once again. I think it's just us now.
Well done, Marvelous and Josephine. How did you feel your first session?
I mean, it was an experience.